I'm telling about any patient come to the casualty department, we have to look for multiple trauma. If patient is come with road of accident or any assault or any other trauma, so we have to look for any life-threatening condition and in neurosurgery we are look for any intracranial hematomas. So today I am telling about the various aspects of head injury management in casualty and after the patient admitted in the ward or ICU according to the patient's clinical condition. So in first initial phase, we have to look for which type of injury is there. So after admission and management of primary management, arterial and venous access, the patient is sterilized, and we go for imaging. Imaging is nowadays first is necessary CT scan, brain CT scan. So we look for any intracranial hematomas. There are different types of injuries we notice in brain after the trauma, right from intracranial hematomas, extradural hematomas, subdural hematomas, subarachnoid hemorrhages, and various types of fractures. So today I am giving the small details of what types of hematomas which are commonly encountered during trauma, during phase after trauma, and during the evaluation of the patient of traumatized in the casualty. So first, and this is most common cause of and most common type of injury is the extradural hemorrhage. So by name, it's understood that it is extradural. So according to anatomy, the brain is covered with three layers. The innermost is pyometer, then second is arachnoid, and the outermost is the durameter. And after above the durameter, there is skull bone. So if any hematoma is situated between the skull and the outer layer of dura, is considered as extradural hematoma. In this picture, we have seen this blue layer is the outermost layer is the dura. There is a this white light color layer is the bone, and this a pinkish layer is the skull. This is skin and subcutaneous tissue, and this is the red considered as a hematomas. It may be cause of arterial bleed or fracture hematomas. Fracture hematomas. So, and these are subdural hematomas. If hematoma is situated beneath the dura, in between the dura and the arachnoid layer. Arachnoid layer is a very thin layer in which where the blood vessels and other vessels sitting in the brain. So first one is the extradural hemorrhage. Extradural hemorrhage is usually caused by uh, injury to the meningeal artery. If there is a injury to temporal lobe, there is a arterial bleed and it leads to sudden increase in the size of hematomas. They are the life-threatening conditions. And another other cause is the skull fractures. Bleeding from the fractured segment of the bone, it is collected in the between dura and the skull bone. So it lead to form the extradural hematomas. So as I see, as I told you, source of bleed is meningeal artery vessels, and these are the mostly arterial veins, mostly associated with skull fractures. Usually they are present with the injury, then lucid intervals and unconscious. It's considered this why it causes lucid intervals. Because many times the patient with head injury, they fall, they got injuries, but amount of blood is not much. So patient is remain conscious, alert, responsive in initial phase of injury. Then as time increases, the vessel, bleeding from the vessel increases and the amount of hematomas gradually increase and increases the brain parenchyma, which will lead to the altered sensory of patient and the patient become unconscious. So many times we notice the history of the patient fall from bike or some accident was there. Patient was initially conscious, talking. He called some his relative, and after 1 or 2 hours, patient becomes unconscious, and we see many times of patients come in very critical condition, and we not able to save his life because of the condition is critical until the patient come to the hospital. The most common side is that the malignancies of temporal pathogen. And as I consider the recent temporary improvement in patient condition after a traumatic injury after which condition deteriorates. And this usually considered it's listened to was especially indicative of an epidermal. And as I told you, there's a basic investigation in any trauma for the head injury patient is CT scan. So in CT scan, we see there's large whitish, the brain parenchyma is grayish, and this whitish is considered the extradural hematoma. So, it's considered lens-shaped, biconvex shaped because the dura is densely adhered at the suture side in the skull. Because here the blood clot is not able to cross the dural attachment of the suture, so it becomes a shape of extradural hematoma. It is considered large because considered as life-threatening because it is gradually increases in the size, compressing the important structures of brain and ultimately lead to the death if not intervened in time. Then, if patient come in, yes, is the size of the hematoma is less. Patient's condition depend and major surgical intervention is the treatment of choice in any type of extradural hemorrhage. If size is big and patient's clinical conditions are not good. So patient of head injury comes in, patient comes in, a patient of head injury comes to you with rapidly decreasing sensorium and with fixed and undilated fluid. Neuroscience and CT machine is not available. We decided to make a borehole to relieve internal pressure, which site will we choose? So as we say, the most common site is temporoparator reason. Most common cause of bleeding is the middle artery. So we think the borehole in the temporoparator region. So amount of blood, if there is, we can remove and which is the intracranial pressure, and patient got that some time to definitive management. So we assess the pupil size. If one pupil is dilated, means if unilateral dilated pupil is dilated, put temporal borehole pupil size of the pupil dilation. If both pupils are dilated, assess which side of the pupil are dilated first. Put a pentaborehole not known, look for site of trauma. If site of injury is visible, put temporal one, this is site of injury. If site is put on the left side, really dominant hemisphere first. So, which side is this type of management is usually done in the primary setup where the CT scans and other facilities are not available. Patient's condition is very critical, and if may patient not survive if not intervened properly. So these are the criteria where we can do the borehole for to save the patient. And another these are for in acute extradural hematoma, surgery is the choice, and surgery should be done as early as possible when the patient comes to the emergency. Patient immediately shifted to the operation theater, and if available, On the way to the OT, the patient is CT scan is done and this comes to the site and the immediate intervention is done. Another common injury we see in the casualty are the subdural hemorrhages. As the name suggests, site of subdural hemorrhage between dura and arachnoid, and main cause of this subdural hemorrhage is the torn cerebral veins. Subdural hematomas compress brain tissue, and it compresses the brain tissue and the arachnoid layer. So this picture shows the where the site was located and what is the cause of the subdural hemorrhage. So source of bridging plexus veins, they are usually presented with impaired consciousness at time of injury and later may worsen due to enlargement of hematomas as opposed to the external hematoma, where patient mainly may present in lucid intervals. In CT, here there is no stoppage or no barriers for the dura to attach with the inner aspect of the skull features. So the hematoma is contour convex shape and is same if amount of bleed is more, midline shift is more, and patient's clinical condition is allowing us. So we are going for the sternotomy and evacuation method. Mortality is much is in this disease. The injury is in the brain tissue along with the bridging veins. So the as compared to external hematomas, a mortality is much higher in the subdural hematomas. External hematomas. Depends on the days after this injury, also type of maybe it's acute, subacute, and chronic. Depend on the time left after the injury. So acute surgery is less than 3 days, subacute 3 to 21 days, and chronic subdural hemorrhage remain in the what one day, sorry. Chronic subdural hemorrhage, there is history of trauma 2 3 where any patient with injury comes to you symptoms 3 weeks later and chronic subdural hemorrhage. Most can be treated by bowel evacuation for non-responsive case care to be done. So in chronic subdural hematoma, the as and as time lapsed, the acute clot of the subdural hematoma is dissolved and it was liquefied.